Hello, I'm Larry Levitt from KFF. Congress is poised this week to pass the Inflation Reduction Act. It would be an understatement to say that this bill, formerly known as Build Back Better, took a few twists and turns to get to this point. But in the end, whether you're talking about the policy or the politics, the healthcare provisions of this legislation are unprecedented, especially the government's authority to negotiate drug prices. The pharmaceutical industry's lobbying armor has definitely been dented with this political loss. And even as the bill has been narrowed in scope, Democrats have gained potent talking points for this fall's election. As our polling shows, policies to reduce drug prices resonate strongly with voters and do so across partisan lines. The policies themselves in this legislation are enormously complicated. Fortunately, we have an all-star cast of KFF experts here today to explain them clearly, which is what we do. Tricia Newman and Juliet Kabansky from our Medicare program will talk about the bill's provisions to constrain drug prices and out-of-pocket costs. Cynthia Cox and Kritika will talk about the enhanced ACA premium assistance, and Molly Brody, who heads up our polling work, will be available to answer questions about how this all plays with the public. Everyone's titles and full bios are available online. The full discussion will be recorded for you to watch over and over again later, should you choose. And please, at any time during the discussion, submit questions using the Q&A button at the bottom in Zoom, and we'll get to as many of them as we can. Tricia, the Zoom platform is yours.
Thank you, Larry, and hello, everybody. The prescription drug provisions included in the Inflation Reduction Act culminate years of discussion and debate. They are significant for at least three reasons. First, they offer the first major improvement in Medicare benefits since the ACA passed in 2010. Second, they not only improve drug coverage for people on Medicare, but they tackle drug prices, which until now have seemed untouchable given opposition from the pharmaceutical industry. And third, these proposals that have definitely been in the policy pipeline for many, many years are now, by all appearances, on a fast track to President Biden's desk for signature. Together, they are expected to lower drug costs for people on Medicare and reduce federal spending on prescription drugs. So, why are drug costs an issue? Can I have the next slide, please? Which is this slide. Nope, the one that was just there. Thank you. Nearly half of all adults take prescription drugs, and among the roughly 65 million people covered by Medicare, virtually all are taking at least one medication. That's why drugs are an issue most of us know something about, because we come face to face with the cost of our prescriptions every time we go to the pharmacy. And while many drugs are low cost and quite affordable thanks to generics and brand competition, I would bet virtually everyone on this webinar knows someone who is struggling to pay for their medications. According to our polls, 83% of adults say the cost of prescriptions is unreasonable. 29% say they didn't take a medicine prescribed by their doctor in the past year due to costs, and 26% say it is difficult to afford their medication. Can I have the next slide, please? The Senate bill includes several provisions that are designed to lower drug costs and prices. The first two listed on this slide focus on prices. The bill requires the federal government to negotiate prices for some of the highest spending drugs covered by Medicare. Under current law, the federal government is explicitly prohibited from engaging in price negotiations on behalf of the Medicare population. This is thanks to a provision called the Non-Interference Clause that was written into law in 2003. That one phrase essentially tied the hands of the HHS secretary from engaging directly in negotiations with drug companies to lower drug costs. It also triggered a nearly 20-year-long debate about whether and how to give the federal government authority to leverage lower drug prices to achieve savings for Medicare beneficiaries and the program. CBO has not released final estimates of the prescription drug provisions in the bill, but as of mid-July, this provision was estimated to save about $100 billion between 2026 and 2031. The second proposal you see requires drug companies to pay a rebate on drugs sold to Medicare beneficiaries if the price of the drug rises faster than inflation. This policy was put in place as a direct response to concerns about annual increases in drug prices, some of which have far outpaced the rate of inflation. CBO expects this provision could lead to higher launch prices in the future. Next is the $2,000 cap on out-of-pocket spending under Medicare Part D. This lowers costs for people who would otherwise pay thousands of dollars for their medications, typically patients who take high-priced drugs for serious conditions like cancer. While $2,000 is still a lot of money, it's less than what nearly 1.5 million people on Medicare now pay for out-of-pocket for their drugs under Part D. The hard cap on out-of-pocket spending will make it easier for people on Medicare to predict and budget for how much they spend on their medications over the course of a year, which matters for seniors living on fixed incomes. Also, the bill eliminates the 5% coinsurance beneficiaries pay after they reach the catastrophic threshold beginning in 2024. That's less than 18 months from now. There are several other provisions, as you can see, but I'll highlight just one more. The bill sets a $35 per month cap on insulin products covered by Medicare plans. The Senate bill had a similar cap on insulin costs for people with private insurance, but that provision was struck down on the Senate floor in a partisan vote. I now want to highlight just a few key implementation dates because we've had a lot of questions about that. Can I have the next slide, please? Beginning next year, in 2023, rebates will be imposed on drug companies if the prices of their drugs increase faster than inflation. Insulin will be covered by Medicare plans and capped at $35 a month. Part D enrollees will not be charged a coinsurance for adult vaccines, such as shingles. That's next year. In the following year, in 2024, Medicare beneficiaries will no longer have to pay a coinsurance once they reach the catastrophic threshold. This essentially caps out-of-pocket spending that year at a little bit more than $3,000. And starting in 2025, the out-of-pocket spending cap is reduced and set at $2,000. Then beginning in 2026, negotiated prices take effect, and that continues on through the rest of the decade. So now, with that quick overview, I'm going to turn this over to Juliette, who will walk through the proposals in greater depth. Take it away, Juliette.
Thank you, Tricia. So let's dive in to the drug provisions in this bill, starting with drug price negotiation. Next slide, please. As mentioned, Medicare is currently prohibited from negotiating drug prices, whether for drugs covered in Part D, which is Medicare's retail pharmacy benefit, or physician-administered drugs covered under Part B. The Inflation Reduction Act empowers the Secretary of the Department of Health and Human Services to negotiate prices with drug companies, but only certain drugs qualify. These include single-source brand drugs or biologicals with no generic or biosimilar equivalents, and that have been on the market for several years. The number of drugs subject to negotiation is limited to 10 Part D drugs in 2026, increasing to another 15 Part D drugs in 2027, and eventually 20 Part D and Part B drugs in 2029 and later years. These drugs would be selected from among the 50 qualifying single-source drugs with the highest total Part D spending and the 50 qualifying single-source drugs with the highest total Part B spending. And I say qualifying because the bill does exempt some categories of drugs from negotiation. The bill also establishes an upper limit for the negotiated price, known as the maximum fair price, and also establishes a process whereby the HHS Secretary develops the government's offer price. The Secretary must consider certain financial and therapeutic factors related to each drug and provide the manufacturer with the justification for the government's offer price. And manufacturers can submit a counteroffer, which also must be justified. A financial penalty in the form of an excise tax would be imposed on manufacturers that do not negotiate with the Secretary, although this tax would be suspended if manufacturers choose to withdraw their drugs from coverage under Medicare and Medicaid. Next slide, please. The timeline for the negotiation process spans about 2 years. Notable here is that for the first year of negotiated prices available in 2026, the list of 10 drugs selected for negotiation would be published just over a year from now in September 2023. This is followed by a roughly 8-month negotiation process between the Secretary of HHS and manufacturers of the selected drugs. And at the end of this process, the negotiated maximum fair prices would be published by September 2024. Next slide, please. Now let's talk about inflation limits. Under current law, the government has no authority to limit annual price increases for drugs covered under Medicare. Year-to-year drug price increases exceeding inflation are not uncommon. The bill requires drug manufacturers to pay a rebate to Medicare if their prices for most drugs covered under Medicare increase faster than the rate of inflation, measured by CPI-U. The base year for measuring price changes relative to inflation is 2021. So if a drug's price in a given year exceeds the inflation-adjusted price calculated for that year, the manufacturer would have to pay the difference in the form of a rebate to Medicare. The rebate would be owed based solely on the number of units of the drug sold in Medicare, but price changes are measured based on the average sales price for Part B drugs or the average manufacturer price for Part D drugs. And these price measures do include prices charged in the commercial market. So in effect, drug manufacturers would have to rebate to the government any revenues from price increases in excess of inflation in Medicare or private plans, although the rebate would be paid only on use by Medicare beneficiaries. Next slide, please. So now let's talk about Medicare Part D benefit redesign. Most importantly, as Tricia mentioned, under the current design, out-of-pocket drug spending by Medicare beneficiaries is not capped. And a majority of high drug costs are paid by Medicare and therefore by taxpayers, not Part D plans or drug manufacturers. The Inflation Reduction Act caps beneficiary out-of-pocket spending and makes changes to the allocation of liability for high drug costs under Medicare. In 2024, the bill eliminates the 5% coinsurance requirement that beneficiaries currently face when they have high drug costs. In 2024, beneficiaries will have to pay about $3,250 out of pocket before their costs are capped. And then in 2025, out-of-pocket spending is capped at $2,000. Beneficiaries will also have the option to spread out their out-of-pocket costs over the entire year rather than face high costs in a single month. And as for who pays the rest of the costs above the spending cap, right now Medicare currently pays 80% of the cost of catastrophic coverage. But under this bill, that share decreases from 80% to 20% for brand name drugs, 40% for generics. And for Part D plans, the bill increases their share of drug costs above the spending cap from 15% currently to 60%. And for drug manufacturers, the bill requires that they provide a new 20% discount on the price of brand name drugs above the spending cap. Next slide, please. This chart shows the cost sharing structure for brand name drugs only under current law and how costs will change under the Inflation Reduction Act. There's a lot going on, a lot of numbers here, but let me just draw your attention to the change above the out-of-pocket threshold, where beneficiaries currently pay 5% coinsurance, which will fall to 0% in 2024, and then the addition of the hard out-of-pocket cap at $2,000 in 2025. Next slide, please. The Inflation Reduction Act will also improve the affordability of insulin for people with Medicare, a drug that was used by over 3 million Medicare beneficiaries in 2020. Currently, insulin costs range from one product to another. And while some Medicare drug plans currently offer coverage of some insulin products at a $35 copay, not all drug plans do. The bill limits monthly copayments for insulin to no more than $35 for products covered by all Medicare Part D plans, and also caps monthly costs for insulin administered through durable medical equipment under Part B. Next slide, please. The bill also expands eligibility for the most generous benefits provided under the Part D Low-Income Subsidy Program, or LIS program. This program helps Medicare beneficiaries who have relatively low incomes and modest financial resources with their Part D premiums and cost sharing. Currently, the income limit for full benefits under the LIS program is 135% of poverty, but this will increase to 150% under the bill. The bill also improves access to adult vaccines in Medicare Part D, Medicaid, and CHIP. Many adult vaccines, like for shingles, are currently available for free to most people with private insurance, but not under Medicare drug plans. The bill would require that adult vaccines covered under Part D and recommended by the Advisory Committee on Immunization Practices be covered at no cost. This would be consistent with coverage of most vaccines under Medicare Part B, such as the flu and COVID vaccines. The bill also requires Medicaid and CHIP to cover adult vaccines with no cost sharing for enrollees. Next slide, please. And finally, the bill would further delay implementation of the final rule issued by the Trump administration, which would have eliminated drug rebates negotiated between drug companies and pharmacy benefit managers or plan sponsors in Part D. This rebate rule was estimated to result in higher Medicare spending and was scheduled to take effect in 2022, but the Biden administration delayed implementation to 2023. Subsequent legislation further delayed implementation to 2027, and under the Inflation Reduction Act, implementation would extend even further to 2032. Next slide, please. In terms of how many Medicare beneficiaries might benefit from the drug provisions in this legislation, we know that in 2020, 1.4 million people had out-of-pocket costs greater than $2,000 in Part D. So they would save money based on the new spending cap. We also know that just over 4 million beneficiaries received a vaccine covered under Part D, so they would no longer face out-of-pocket costs for these products. And roughly 500,000 Part D enrollees received partial low-income subsidy benefits, so they would receive more generous levels of financial assistance with Part D premiums and cost sharing. These estimates are likely to be conservative because they don't reflect increases in drug spending since 2020 or enrollment growth, or growth in use and spending of drugs associated with reduced financial barriers in this bill. So this was a lot of ground to cover in a short time, and I'm sure there are questions, but first let me pass things over to Cynthia Cox to explain more about the ACA subsidies in this bill.
Thank you, Juliet, and hello, everybody. So we're going to change gears a bit now, and I'm going to be talking about the health coverage provisions in the Inflation Reduction Act. But first, I just want to say that for people who have been buying their own health insurance, recent health reforms have been a bit like a play that has unfolded in 3 acts. So Act 1, of course, was the Affordable Care Act, which included subsidies to help people with their premiums. But these subsidies kind of topped out at an income of about $50,000 for a single person or about $100,000 for a family of 4. Now, that's a pretty good income in most parts of the country, but it's often not enough money to afford full-priced health insurance coverage on the Affordable Care Act marketplace. So some of these families were caught in the so-called subsidy cliff, where Some families were paying 20% or more of their income on health insurance, and that's before even accounting for the deductible that they might have to meet too. And other families were just priced out altogether. So there were also concerns on top of that, that even for the people who were eligible for a subsidy, some of them weren't taking it up. And so for years, ACA supporters argued for more expansive subsidies, and President Biden in 2020 campaigned on building upon the ACA. So that brings us to Act 2, the American Rescue Plan Act. And it was a COVID relief package that passed last year, and it temporarily removed that upper income limit on the ACA subsidies. So it did away with the subsidy cliff that I just described. The ARPA also increased the amount of financial help that lower income people got who were already eligible for subsidies, but now they got a boost for their subsidy. So what happened was that there was a record-breaking 14.5 million people signing up for coverage, including about 13 million people with enhanced subsidies. But again, these enhanced subsidies only lasted for 2021 and 2022. So at the end of this year, if Congress did not act, virtually all of those 13 million people who were getting enhanced subsidies would have faced an increase in what they have to pay for their premium. And some would lose eligibility for subsidies altogether. So that brings us now to Act 3, the Inflation Reduction Act, which will continue the American Rescue Plan Act subsidies without interruption for 3 more years through 2025. This will prevent steep premium increases that millions of people would have faced if the ARPA subsidies had been allowed to expire. But again, the Inflation Reduction Act subsidies are only temporary, expiring now at the end of 2025. So at least for now, we're left with a bit of a cliffhanger, and we'll see if there's an Act 4 in 2025. Next slide. So I'm going to share some slides with some data here to just illustrate some of the points that I just made. The first chart shows that it's an estimate of eligibility for subsidies, both among people who were already getting subsidies and for those who were not taking up subsidies before the ARPA. And as you can see, the ARPA made millions of people eligible for subsidies, particularly people who had incomes above 4 times the federal poverty level. And the Inflation Reduction Act would continue that eligibility for another 3 years. Next slide. The Inflation Reduction Act would also continue to lower premium payments across the board for lower income enrollees as well, just as the American Rescue Plan Act had. So the light blue here is showing how much of an additional subsidy the ARPA added and that would continue to be there under the Inflation Reduction Act. And one important thing I want to point out here is in that second column, you can see that someone who has an income just above the poverty level would pay nothing for their premium because it would be fully subsidized by both the ACA subsidies with the additional subsidies from the ARPA, which would be continued by the Inflation Reduction Act. So essentially what that means is that very low income people are paying nothing for their premium, and they're also getting a lot of help with their deductibles, so their out-of-pocket costs are low too. Next slide. Now, if the Inflation Reduction Act did not pass, we would have seen premium payments increase across the board for virtually all 13 million subsidized enrollees. On average, premium payments would have been about 53% higher, or more than $700 per year higher on average, but that varies depending on the person. So without the Inflation Reduction Act, there also would have been a return of the subsidy cliff, which is illustrated in this chart on the right here. So on that y-axis, we have the share of a person's income, in this case, a 60-year-old's income, that they would have to pay towards the premium of a silver plan on the marketplace. The x-axis here is that person's income. So you can see as someone's income rises, they have to pay more, both in terms of dollars and as a share of their income on their premium. And if the Inflation Reduction Act is signed into law, then it caps out as a share of one's income how much they have to pay. But if it weren't for the Inflation Reduction Act, then at an income of $50,000 for a single person or thereabouts, there would be a steep rise in how much they have to pay because they would lose eligibility for subsidies. And assuming the Inflation Reduction Act passes, that's not going to happen. There's not going to be that steep increase in premium payments. And also the Inflation Reduction Act would prevent what could have been a double whammy for some of these enrollees, and that's illustrated in the green line there. So for some enrollees, if it weren't for the Inflation Reduction Act, they would not only have the hit from the loss of subsidies, which is the orange line, but on top of that, they might have had to pay a premium increase, an increase in however much the underlying or unsubsidized premium rises from this year to next year. So the Inflation Reduction Act will prevent that as well. Next slide. So all of the charts I showed so far were national averages, but I do want to also make the point that the impact of the Inflation Reduction Act varies by state. So without the Inflation Reduction Act, people in the subsidy cliff income range, especially living in high premium states, so that would be, for example, West Virginia or Wyoming, they would see the steepest premium increases. Or at least increases when they have to pay for their premium because they would lose subsidy eligibility. They would be faced with the underlying cost of the premium, which is highest in those states. But again, the Inflation Reduction Act, if signed into law, will prevent those premium increases. But of course, these enhanced subsidies cost money. So I'm going to turn it over to Kritika, who's going to talk about the impact on the federal budget.
So that's right. Continuing extra subsidies for another 3 years will come at a cost. The Congressional Budget Office estimated that extending the American Rescue Plan Act enhanced subsidies permanently would cost about $25 billion a year. And that's a result of increase in net new subsidized enrollees. Also, premium tax credits for people already getting subsidies would increase, like Cynthia was showing earlier. For a 3-year extension, CBO may make slightly different assumptions. And as the saying goes, all models are wrong, but some are useful. How much the expanded subsidies actually end up costing the government will depend on how many enroll and what the future premium trends look like. In 2022, 14.5 million enrolled for marketplace coverage. That's a net 2.5 million increase from before the extra help was available. Compared to that, CBO estimated nearly 5 million new enrollees would sign up every year. CBO is also modeling future premium trends, including as a result of the risk pool changes with the new enrollment. The broad-based health sector inflation and pricing utilization also affects premium tax credits. We reviewed ACA markets rate filings in 13 states and DC, where we found a median increase of 10%. So how much it will end up costing will depend on these factors. The cost of extending enhanced subsidies is balanced out by savings and revenue elsewhere in the legislation. And with that, I'll pass it back to Larry for questions.
Terrific. Thanks, everyone. As clear and comprehensive as those explanations were, not surprisingly, as we started to peel back the onion of this complex legislation, it raised a lot of questions from the audience. So we are going to jump into those. And let me start. There were a number of questions about how these pricing restraints in Medicare might affect prices in commercial insurance plans, employer plans, plans that people buy on their own. Are there any protections for price increases there? Would there be any spillover effects from the Medicare changes? Tricia, maybe I'll start with you.
Well, I think there is that possibility, and CBO mentioned that that was a possibility in the context more of the inflation rebate, that they thought it would increase launch prices, both for Medicare and outside of Medicare. So, I do think that's a possibility. With respect to negotiations, there were provisions written into the bill that would certainly protect Medicaid. I think it's fair to say that drug companies have an incentive to maximize revenue and prices. So there is that possibility.
Juliet?
Yeah, so with regard to the inflation provision, while there is the thinking that that would lead drug companies to bring new drugs to market with higher prices, it's also the case that that provision will help keep prescription drug price growth in check for existing drugs. And that will have spillover effects for people in Medicare as well as people with other types of insurance. Since if manufacturers increase their prices faster than inflation, they will owe a rebate to Medicare. The other thing I guess I'd like to say with regard to negotiation is that drugs can't be selected for negotiation if they're the newest drugs in the marketplace. So manufacturers will still have an opportunity to generate revenue based on, the latest and greatest drugs that come to market. Those drugs won't be selected for negotiation or eligible for selection for several years. We're talking 9 years for brand name drugs and 13 years for biologics. So I think that still provides the pharmaceutical industry with plenty of incentives to continue to invest in research and development and know that when they bring those new drugs to market, they will be protected from any form of price negotiation for several years after coming to market.
Great. And I would add, the way the inflation rebates work, the restraints on drug price increases, it's likely to have a differential effect from drug to drug. So for example, drugs that are used primarily by Medicare beneficiaries, we're likely to see even tighter restraints on price increases because of the rebates that have to be paid to the federal government. Drugs that are used largely by people other than Medicare beneficiaries, let's say kids primarily, there are likely to be not very many restraints because of the way the rebate formula works. So Juliet, let me stick with you. You talked about the drugs be selected for negotiation, and there were a whole bunch of questions about that. Where's a list? Can I get a list of the top 50 drugs? How many of these drugs might be Part B drugs versus Part D drugs? You have all the answers to that, right?
Sure. So with regard to, let's just take one, Part B versus Part D. The vast majority of drugs that Medicare covers are covered under Part D, the outpatient prescription drug benefit. So we would, and that's where, most of the high cost drugs are, because that's where most of Medicare covered drugs are. So we would expect that, and in fact, we did a simulation of this provision, and what we showed was that, of 20 drugs that could be potentially subjected to negotiation in 2022, 18 of them were Part D drugs and 2 of them were Part B drugs. So I think that we can expect that that will be somewhat, approximately the allocation of B versus D. I know there are also questions about 10, 15, 20. Is that, is 20 the cap, or is this a cumulative number? And it is cumulative. So it's 10 drugs that will have negotiated prices available in 2026, another 15 drugs in 2027, another 15 drugs in 2028, and then another 20 in 2029 and beyond. So I know that, there's been some concern among some who maybe wanted to go further with the drug negotiation proposal in terms of negotiating for all Medicare covered drugs, or 50 or 250. I think it's important to note that these numbers are cumulative, not sort of an absolute number of 10 and then 15 and then 20.
And just to clarify, you're not hiding any secret confidential information that you're aware of about exactly which drugs are going to be negotiated.
Right. No. So in terms of, which drugs will be subject to negotiation, like I said, in my slides, according to the timeline for the first year when negotiated prices will be available in 2026, we will know a year from now, based on drug spending data, from the next 12 months or so, which 10 drugs the secretary will be selecting for negotiation. So we don't actually have to wait that long for at least the beginning of the negotiation process for the drugs that will have negotiated prices in 2026. But so much of this is subject to future spending data that it really is difficult to know exactly which drugs will be subject to negotiation as we sit here right now.
So Julia, you talked about 2026 when the negotiated prices actually take effect, and that's a good segue into a question we had about the politics of this. Could this actually be undone by Congress in advance of 2026, let's say after the 2024 election? And Molly, maybe I'll bring you in. So how do you expect this to play in 2024 election is a long time away, but let's say the 2022 election, and how does the public view all of this?
Yeah, I mean, I think at the first step is that this is really, it provides a great opportunity for candidates in 2022 to talk about something on the campaign trail that's incredibly popular. And that's true for candidates across the political spectrum, because really, no matter what your political identification is, the public does really care about prescription drug prices. They worry about them. As Tricia pointed out, it's something that touches virtually everybody's life. So they're really keen on this topic. And the provisions that we've been discussing today are quite popular across the board. So it is a really good campaign topic. If you go the next step and say, well, is it going to actually matter? Is it going to be a decision-making, an issue, a voting issue in 2022? I think it's a little bit less likely to be that. There are a lot of things on people's minds. What we really think about as we're thinking about the outcome of an election is who's going to turn out to vote, and will any of this motivate different, or additional people to turn out to vote? Maybe at the margin. Will it change a vote, change somebody's likelihood from voting for one party to another? Maybe in some races, but there's a lot of things on voters' minds right now. Inflation, the Dobbs decision, a few other political things that are going on. So in terms of an actual voting issue, I think that's less likely to be the case, but certainly it's a really great opportunity for candidates to talk about something incredibly popular on the campaign trail.
Thanks. And independent of how it plays as a voting issue or how it factors into votes, the outcomes of elections matter. And if control of Congress switches, control of the White House switches, there would certainly be opportunities to repeal or slow down some of these provisions. Certainly on the drug pricing side, but on the ACA side as well. Cynthia, this averts a premium shock that would have occurred, and in fact, consumers would have gotten notices of that premium shock right before the midterm election. That will be averted, but there is still a risk of a premium shock when this temporary extension expires, right?
That's right. So, what would have happened if the Inflation Reduction Act does not pass or did not pass? It would be a 53% premium increase, at least. Maybe some people might face more, some people might face less, but it would be a pretty steep increase. And so essentially what the Inflation Reduction Act is doing is it's kind of delaying that for 3 more years. But if and when those subsidies do expire, then people are going to lose that enhanced subsidy, which means they're going to have to pay more each month, in some cases a lot more. So the question is will whoever's in charge in 2025 find a way to continue extending these subsidies, or will they eventually expire?
So we had a bunch of technical questions about how this all works. So I want to dig into those. And we had several about what this means for Medicare Advantage plans versus traditional Medicare fee-for-service. Tricia, does this all these, the cap on out-of-pocket costs and negotiated prices, do those all apply in Medicare Advantage plans as well?
Yes, they do. So for people who are in Medicare Advantage, they're still going to have the benefit of getting the $2,000 cap, just as people in traditional Medicare, because really the drug benefit is its own thing. And so it applies for traditional Medicare. It applies to private plans that people in traditional Medicare purchase, the standalone drug plans, and it applies to Medicare Advantage plans. So yes.
And then several questions also about what this means for premiums. Juliet, you talked a lot about the out-of-pocket costs. What about premiums? Will they go up? Will they go down for Part D, for Medicare Advantage?
So the premium question is somewhat difficult to know in terms of, the precise direction of effect. We could expect that some of the provisions, the price negotiation and the inflation rebate provision, could help to keep, they're designed to keep spending growth in check, to save the federal government money, and that will translate into lower plan costs. But sort of pushing in the other direction, the Part D benefit is getting more generous with the addition of the out-of-pocket cap, and we're expecting plan costs to increase because their share of the high drug costs for catastrophic coverage is increasing from how much they pay today to a much larger percentage. So there are kind of forces pulling in different directions. The legislation does include a provision to help stabilize Part D premium growth between 2024 and 2030 in the scenario where Part D premiums on average increase at a faster rate. The legislation will cap the average premium at 6% from the prior year. But that doesn't necessarily get triggered if plans are actually able to kind of keep drug price growth in check and submit bids that are lower than that 6% increase. But at the end of the day, I think just as we have in the Part D marketplace today, Part D premiums are all across the map. There are really cheap plans and there are really expensive plans. And beneficiaries can choose every year to switch plans if they desire cheaper coverage that meets their needs. And I will expect that to continue to be the case moving forward, even after all of these changes are fully implemented over the next several years.
And Julia, let me stick with you. There were also several questions about how this interacts with the way the plans currently negotiate prices for drugs. We have these drug plans, we've got these Medicare Advantage plus drug plans. They contract with PBMs. Sometimes the PBMs are one and the same as the insurance company. Sometimes they're separate. They get rebates behind the scenes. How will these government negotiated prices interact with whatever those insurers and PBMs are doing?
Well, these government negotiated prices, ideally by design, will be lower than what the private plans are able to negotiate today. That's sort of why they've designed this negotiation process the way they have in terms of drugs where there's kind of a market failure. These are drugs, brand name, single source drugs that have been on the market for a long time. There's no competitor products available. And so we think that in cases of drugs such as these, plans don't really have that much negotiating power, because if a drug company kind of has a monopoly on the market for a particular product, they don't really have to give really steep discounts. So, we were bringing the government in where there hasn't been maybe the ability of plans to do a lot of good negotiating to get steeper discounts. So that's why things are structured the way they are. And the government negotiated prices will be made available to all Part D plans so that those prices can then be passed along, in the form of lower copays and coinsurance for people who are enrolled in both Part D standalone plans and Medicare Advantage plans. And all of the drugs that are subject to the price negotiation process have to be covered by Part D plans. So those drugs will be available to everyone in Part D, and the lower government negotiated prices will also be available to anybody in any plan who needs one of those medications.
So Tricia, that raises another question that a listener asked about drug formularies, the list of drugs that plans cover and that are covered in Part B, physician administered drugs in Part B. How will this affect those formulas? Can there still be formularies? Can plans restrict the drugs that are covered beyond, let's say, the negotiated prices? Will they?
Well, plans already have some flexibility. They have to provide all the drugs in certain protected classes, and they have to provide 2 or more drugs for other types of classes. So they will still have flexibility. They will still have flexibility when it comes to insulin products. They won't have to cover every product that's out there. So this in some ways will be no change for the plans, except they will have to cover the negotiated drugs. And, I think, I also saw a question come in about, will this mean fewer drugs because of the negotiated prices? And I think that the drug companies and Medicare have an incentive to have drugs covered. When a new and expensive drug, or not so new, once it's negotiated drug comes to market and it's really effective and innovative, everybody wants to have access to that drug. So the whole point of it is, let's find a reasonable price and let's make that drug available to people. There's no intention here to keep good drugs off the market.
So Tricia, you mentioned insulin, and there's been a lot of confusion about what happened on the Senate floor with respect to the cap on insulin copays, and we had a couple questions to try and clarify that. So Tricia, just clarify, what did the Senate do to change the bill, and who will have their insulin copays capped and who will not?
When the bill came to the floor, there were basically 2 pieces. One piece would provide a $35 cap for Medicare, $35 a month on insulin products for Medicare, and another would provide a similar $35 a month cap for people with private insurance. That bill, the parliamentarian raised questions about the private insurance part of the legislation. And the Democrats said, okay, well, it's really important. Let's waive this rule. Let's waive the point of order so that we can keep this, because we understand that insulin really matters and it's expensive for people, whatever their age is. So the Democrats tried to keep this provision in the legislation, but there was a vote on the Senate floor. The vote needed 60 votes to keep that particular proposal in, and it didn't have the 60 votes it needed, even though I think 7 Republicans joined with the Democrats in order to cap insulin costs for people with private insurance.
So that vote jettisoned the insulin copay cap for private insurance, but the cap for Medicare remains.
Exactly.
And Kritika, what does this mean in the private sector? I mean, would there have been savings for people if copays had been capped for insulin at $35?
Yeah, so in the private market, about 1 in 5 people who take insulin pay more than $35 a month for insulin. And nearly a third of people with small employer insurance pay over $35 a month. And so how much those people would have saved depends, but at least half of those people who pay more than $35 would have saved at least $20 a month.
Got it. And I fully expect Democrats, even though this bill does not cap insulin costs for people with private insurance, I fully expect Democrats to bring up the Republican votes against that cap during the campaign. Julia, back to you. More detailed questions about how this all works. The $2,000 cap on out-of-pocket costs. So there were several questions about this. I'll ask them all of you, and you can address them one by one. First of all, how does that relate to deductibles? Any deductibles that people may face? Does that count towards the cap? Is that in addition to the cap? Does the cap apply to everyone, or is it restricted by income or any other factors? And if you could try to explain how the $2,000 cap relates to the catastrophic limit and what will happen to people in the first year this takes effect when the 5% coinsurance above the catastrophic limit is eliminated, and how does that relate to actual out-of-pocket costs that beneficiaries pay?
Sure. So the deductible applies to the $2,000 cap. So take this year, for example, there's a $480 deductible. Not all plans charge it, but if you're in a plan with that deductible and we had a $2,000 cap today, you spent $480, then you would just have to spend another $1,520 before you reach the $2,000 cap. Sorry, what was the second question now? I forgot. I've forgotten what it was.
Sorry, I should not have thrown all this at you at once. So are there any restrictions as to who qualifies?
No, it will apply to everybody. So it's not an income related benefit or cap that only applies to people with low incomes. I mean, I should note obviously that because Part D already does have a low income subsidy program that helps people with incomes up to 150% of poverty. Assuming this bill actually passes and the expansion of the full low income subsidy benefits take effect, anybody who's receiving low income subsidy benefits already has financial protection in the form of a spending cap. They don't pay above a certain threshold right now, and that will continue to be the case moving forward. And then as far as sort of what's happening in 2024 versus 2025, right now under the Part D benefit, there is kind of a very strange way that people move through different phases in terms of their cost sharing. So there's a deductible, and then there's a initial coverage phase where under the standard benefit, people pay 25%, but actually most people pay some form of copay, like maybe $15 or $20 for brand name drugs. Actually, it's more than that, but then they get to the coverage gap phase and they pay 25% of their total drug costs. They get a 70% discount from manufacturers on brand name drugs until the combination of their actual out-of-pocket costs and the value of that manufacturer discount equals in 2022 just over $7,000. That translates into actual beneficiary out-of-pocket spending of just over about $3,000 this year. That will tick up to, I think, around $3,100 next year. And in 2024, when that 0% coinsurance takes effect above the catastrophic coverage threshold, people's actual out-of-pocket expenses will be around $3,250. Then in 2025, that out-of-pocket cap is actually lowered from that $3,200 amount to $2,000. So there will be significant savings for people who have really high drug costs or take a lot of expensive medications between 2024 and 2025. But in 2024, people who are now exceeding the catastrophic coverage threshold because they have high drug bills will see real savings associated with that 0% coinsurance before the $2,000 cap takes effect the next year.
So can I just add, that is essentially like a cap that takes effect in 2024. We've all been hearing a lot about that $2,000 cap in 2025, but from a beneficiary perspective, they will know in 2024 that they will spend no more than that figure Juliet just said, about $3,200 that year and no more. So essentially the cap is in effect in 2024, and then it drops again in 2025. Senate bill.
I'm going to let all that sink in for a second for everyone and switch gears a little bit. We had a question about the, back to the ACA, the Affordable Care Act, the family glitch, whether this the Inflation Reduction Act fixes the family glitch. Cynthia, maybe you can explain what the family glitch is and whether the legislation does fix it.
So the family glitch is something that came about in the Affordable Care Act, where generally speaking, people who have employer coverage that's affordable are not allowed to get subsidies on the ACA marketplace. But there are some exceptions. So if your health plan that your employer offers is unaffordable by a certain definition, then you can get those subsidies on the ACA marketplace. Now, the glitch here is that the way that someone's affordability is calculated only is based on the employee's cost, not on their family member's cost. So if they have dependents, a spouse or kids, they might have to pay a large amount of their income on their employer plan and would still not qualify for subsidies on the ACA marketplace. And we've estimated that about 5 million people who are dependents on their, generally speaking, are dependents on their spouses or parents' employer plan fall into this glitch. So the Inflation Reduction Act does not directly address this glitch. However, the Biden administration has proposed a administrative fix to the family glitch. Kritika, you have worked on this too, so if you want to elaborate on that, you can.
Yeah, so like Cynthia said, there are about 5 million people who fall into the glitch. Some of them already have insurance, and so some might find it that it's cheaper to go on the exchange and get insurance. The insurance also provides cost, the exchange may also make certain cost sharing subsidies available if they are below a certain income. But how many people enroll with a family glitch fix will depend.
Great. So Molly, let me turn back to you. There was a question about the polling and the politics, and in particular, whether pharmaceutical industries advertising during this debate by themselves, by front groups, had any effect on public opinion, and maybe talk a little more broadly about how the arguments that the drug industry has been making resonate with the public.
Yeah. So in general, other than the 2,000 of you who decided to come and watch this today, the average person, hears bits and pieces of things and can only, pay attention to so much. They've got lots of things going on in their lives. They're trying to put food on the table. They're trying to get their kids to school. They're trying to avoid COVID infection, whatever. So getting really into the details is tough. So advertisements can get people to focus on a particular part of any kind of policy debate. So what we've seen in all of our polling is that whenever we just ask about any of these sort of drug provisions and trying to improve drug prices, which is something people really care about, lowering drug prices, we know that people support kind of a large range of provisions to do this at first ask, right? Sort of their gut impression is like, do something about this. As we said before, lots of people go to the pharmacy regularly. They see the cost of their drugs. They worry about the price of drugs. The American public has sort of a love-hate relationship with the pharmaceutical industry. They really, really, really appreciate their products, and they really give them a lot of credit for changing people's lives with these great drug innovations. And people recognize that the new drugs and all drugs have made people's lives better. On the other hand, they think that the costs that they charge are unreasonable, and they think that they're too focused on profit. And they don't have any confidence. The vast majority of Americans don't have confidence that what pharma is suggesting for the country is in the best interest of the country or in the best interest of people. So, so every pharma ad, I imagine, will be taken with some grain of salt, because the American public has a little bit of a sense of, well, you're doing this because you just want to make sure you're maintaining your high profits. And I already believe that about you. On the other hand, when we talk about these particular provisions and we start testing some of the arguments that both the proponents and the opponents have made, we find that opinion can be malleable when you talk about one argument or another. So when you raise fears that certainly the pharmaceutical industry has raised, that any kind of negotiation is going to lower the number of research and development, that's something that scares people, right? And so you can see opinion being more malleable, and all of a sudden you could see drops in support when people are told arguments like that. On the other hand, if you tell them other arguments about lowering costs, but it won't reduce the arguments the advocates might make, you see different kinds of changes. What we've tried to do in our polling is really mimic what the public debate has looked like recently, and given people both the proponents and the opponents' arguments. And when we do that, we see actually very little change in people's overall support. And so when we've read the proponents' strongest arguments and the opponents' strongest arguments, we find that support and favorability remains at 83% across the board. it's 71% for Republicans, it's 90-something% for Democrats, but across the board, even after hearing all the arguments and trying to sort of mimic what the real public debate has looked like in the past few months, we see very little changes in public opinion on this. And then the last thing I'll say is the underlying arguments that especially pharma has been using, the public doesn't find in general that it's convincing. So this argument that they have to charge higher prices in order to produce new drugs, when we ask people if they find that convincing or not, most people say they don't. They actually think that the pharmaceutical industry makes plenty of money to also incentivize them to come across with new drugs. So that fundamental sort of belief that there's a need to keep these high prices and to really protect pharmaceutical companies is not necessarily there. And then the last thing I'll say is that, you know what, this idea of negotiating prices, right? We do it all the time in America, right? Like it's a basic principle of American business. We negotiate for our houses, we negotiate for our cars, we negotiate our contracts. So this the idea of allowing Medicare or the government or anybody to negotiate prices, it seems a little weird to people that you wouldn't do that, because again, it's just a fundamental capital marketplace activity. So why wouldn't you be able to allow it to be negotiated? So that's a lot of information to say that it is easy to scare people away from things when you really focus on just one side of the argument. But if you present people with sort of the full picture, we generally find that over and over and over again, the vast majority of the public finds these sort of provisions and any efforts to try to reduce drug costs is something that they support.
Well, that's an excellent preview of, I think, what we're going to see in the upcoming campaign. And unfortunately, we're at the top of the hour and need to end there. But I want to thank all of the KFF experts for a tremendous discussion. Thanks to all of you for joining us and all of the excellent questions. I apologize we did not get to even a fraction of them, but keep watching. Come to kff.org. We will certainly be following this closely in the months and years ahead, and keep a lookout for a recording of this later today. Thanks again.